Welcome to another episode of Health Matters with PA Lynn Szabo. I'm Heather, and what are we going to talk about today, Lynn?
We're going to talk about screening for prostate cancer. But first, I want to say from all of us at KFUG, we want to extend our deepest sympathies to the family and the loved ones of Alex Preddy, RN, who was brutally executed yesterday in Minnesota. I just want to say our hearts are with you.
Yeah, that was absolutely devastating, and what happened to Keith Porter and to Renee Good as well.
Yeah, absolutely.
Absolutely shocking.
The world is watching, guys. So today's topic is prostate cancer. More like screening for prostate cancer.
Okay.
So we should probably identify what a prostate is, because it's kind of like an under-the-wire little gland. Prostate is a gland surrounding the neck of the bladder in male mammals, and it releases fluids that support sperm on their merry little journey.
Alrighty.
So, yeah. And as men age, it can cause all kinds of problems. But today's focus is cancer and how screening for prostate cancer should be done in a way that makes sense. So what I usually get is middle-aged man whose wife is having him come in to ensure that he stays healthy, which is an amazing, loving thing to do. He doesn't really know why he's there, though, or what he should ask for. But usually on the list, somebody has written down, get your PSA. So prostate-specific antigen is a blood test that has been used and was hoped to have been a screening for prostate cancer, but that's not really what it is. So we'll talk a little bit about what it represents and what a result, or what even doing it or not doing it, what would be a good idea.
Okay.
So a minor but important aside, there's an important idea in medicine that you order tests to provide information that actually answers a specific question being asked.
Okay.
Okay. So that's probably why you need a provider to order stuff, because a lot of people...
So that'd be like a pregnancy test. Are you or are you not pregnant? That's the specific question. There's a specific test.
Right.
So...
Right. And then, but what's the parameters of a pregnancy test? Are there false negatives? Are there false positives? I've seen positive pregnancy tests on men.
I've seen false negatives all the time.
All the time.
With women who definitely are pregnant.
Right. And I have seen that too. And there's timing issues involved. But for the prostate-specific antigen, really what you're asking is, does this person have cancer? It's like being used as a screen for cancer, and that's not really what it is. So that's my point.
Okay.
It's important to consider if the test that is ordered is providing the best information to address the question you're asking.
So now I'm right. So the question my thought would be that the question on that is that do you not have prostate cancer? So what is that test for if it's not for that? I don't understand.
It's actually for monitoring therapies for somebody that already has known prostate cancer.
Oh.
And
so it's not for diagnosing, it's for monitoring.
It's not like a pap smear and an HPV test that'll tell a woman if she has a cervical problem or not.
Well, how the heck did it become known for being the thing that diagnosed prostate cancer?
Because I think initially that was the hope. But as they use the test more, they see that it actually is giving us different information. That's why your provider sometimes will order testing that you weren't expecting, or doesn't order the test that the internet thinks you need. All right?
Gotcha.
Because your provider's defining the question on the table and then addressing how you get information for that.
Okay.
Okay. And
so get a good provider, trust your provider, and do the test your provider says, not what the internet says.
Gosh, what a concept.
All right. So provider Google is not a thing. Provider Lynn is. Okay.
Yeah, well. So refining the question is the best, is one of the things that your provider is supposed to do for you, right? See what your concern is, refine the question, Find the resource that addresses it directly.
Okay.
And so this includes the idea that sometimes tests, well, we've already touched on this, sometimes tests give false positive results. So a false positive is a result that which is incorrectly indicating a particular condition. Okay, so a high PSH or kind of a moderately elevated PSA, what kind of sounds like, oh my God, I got cancer.
Yeah.
But that's not really what it is.
Okay.
That's not what that's saying. You can, if you went on a long bike ride that weekend, okay, and you're sitting on a bike seat, that can elevate your PSA.
Okay.
If you just had a digital rectal exam for somebody to check for nodules on your prostate, that can elevate it. If it's been infected recently, that can elevate. So it's too sensitive and not specific enough. Does that make sense?
Yep.
Yeah. So the average generic man, as they age, the risk for prostate cancer increases approximate with their age. So, for example, a 90-year-old man has a 90% chance of having prostate cancer. That's just average generic aging guy.
Wow. I did not realize it was that prevalent.
Okay. But let's also remember that cancer is kind of a big word. And there are, as far as prostate cancers go, there's a lot of different kinds.
Okay.
So most aging men just have a little spot of abnormal cell growth that isn't really going to amount to anything in their lives.
Because it's so slow growing and they only have 20 years left and it's
Right.
going to take 40 years to be an issue, then you're going to be in the ground
Do you really
already.
want to drag them through a procedure that's going to leave them unable to perform sexually or incontinent of urine or with chronic pain?
So that's why now when our grandpas are diagnosed with prostate cancer in their 70s, there's no surgery and there's no radiation or chemotherapy. It's just kind of like, we'll wait and see and we're going to monitor this.
Yeah, it becomes what we call in medicine watchful waiting. So you're not in denial about it. You're kind of keeping an eye on it and seeing how it progresses.
Okay, so if it does end up turning into something that's going to grow rapidly, that's when you address it in a rapid manner.
Right.
But if you're going to be dead long before it ever becomes an
Yeah.
issue that it's going to kill you, then
Right.
okay.
So why should you have a prostate removal or a biopsy that renders you incontinent of urine for your life? I mean, you see how much misery that is for
Yeah.
something that was never going to be a problem anyway?
Yeah. Well, there was a huge problem for the people in the 80s and 90s and the early 2000s who had those
Right.
procedures done because they were told they had cancer.
Yeah.
Okay.
So we have to remember that there's a continuum of types of prostate cancer. Some are genetic, some are probably just a result of aging, kind of accidental. Some are very aggressive, and some, if you didn't know they were there, you never would have known they were there. You know?
Gotcha.
They're
So
never,
it's like an incidental finding. It wasn't
Yeah.
because you had symptoms.
So with prostate cancer, screening is important to focus on what could cause harm. Okay.
Shouldn't all medicine be focused on what should cause harm?
Right. Because what's
Not just a man's
what's the
prostate.
Hippocratic oath? First,
Do no harm. All right.
Yeah. So,
I'm jinx, by the
but
way.
it's jinx, you owe me a Coke.
Sorry.
So the real question being asked here with generic, let's say 50-year-old man coming in with a paper with questions in his wife's handwriting, what should we really be doing for that person who has no risk, who's going to be around for a while, who's really active, vigorous, he's chopping wood and he's, still working. And I mean, what should we do to that person to do the least harm and get the most specific information that we need? Well, there's no real good answer yet, is the bottom line.
Okay.
So the risk-benefit ratio of testing needs to tilt in the direction of the benefit. There you go. So the other annoying thing about this that we have to understand is that after a certain age, screening tests take into account the life expectancy of the patient. I mean, what the average life expectancy would be. And this is a hard conversation to say, hey, you're like 78 years old. You don't really have a risk. You're headed to the off ramp of the freeway, and
You've got one foot in your grave and the other on a banana
Yeah,
peel, and
and
your wife's pushing from the back. So we're not doing this for
and
you.
we don't care anymore because denial's probably a good thing, and something's going to get you before then.
Yeah.
That is a very hard conversation to have with a patient.
It really is. I remember when my dad, the week he was passing away, he'd already lost one leg to peripheral artery disease and not getting the getting circulation. So they
Right.
took his right leg off. I actually have his prosthetic. And so that week that he was passing away, I literally asked if they were going to do the test to see if he was getting circulation in his left leg. And the nurse went, "Oh, honey." And I was just, I am so sorry. And then we kind of just chuckled about it, right? Because I was like, you're going to do this massive surgery and take away my dad's leg days before he died
Right.
of his heart problems. It made no sense to even do that test. We know his leg is dying. So is he. Why do this massive surgery and torment him just before he dies? So I get what you're saying. And it is that hard conversation to have because I wanted him to have care. And it was just like, oh, no, you're right. Okay. I just have to accept he's passing away.
And let me just add that I have seen in my practice men when they were getting PSA. Remember, I've been in practice for about 40 years. When they were getting PSAs in a more regular way, who were relatively young, and then come back with a borderline high PSA, and they are flipping out.
Yeah.
Because to them, that sounds like they're going to prematurely die.
Yeah.
When really, maybe it was the bike ride,
Yeah.
Maybe, the surgery is going to make their quality of life a lot worse. All these things, it's very, very hard to explain the nuances. So
It really is. And then right, as the patient, you're scared and
Right.
you're trying to make all of those decisions and you're living with the memory of like my grandfather had this. And I remember what it was
Yes.
like for him. And,
Yes.
and I I got tests back and they were very reminiscent of the illnesses my brother had. And it wasn't, I was afraid for me. It was reliving the last 10 days of his life every single day over and over and over again, like some form of grief PST, or it was just, it was really hard. I'm still doing it, even though I know my tests are fine and I don't have the same illness he had.
Yeah.
It's scary and it's heartbreaking. So, and it's not logical. We need to understand it's not logical. And if we have that relationship with our provider, we need to be able to trust our provider.
Well, the other thing too is that recommendations change over time. So it's not just a single conversation, it's probably a series of conversations. But this kind of stuff is easy. Healthcare and maintenance is easy to just kind of get swept under the rug when you have the flu and you're miserable and you don't want to hear about. Well, if you get your cholesterol done fasting, you just want to give me the antibiotics, which is not indicated for the flu, folks. Sorry.
Yeah, it's really not.
Yeah. So
Your job's really hard. I'm sorry. Just
there's shades of nuance. That's why PAs are really taught to talk to patients. Because if, as an aside, if you think about what we do all day, is that we take a concept in patient talk, we translate it to medical talk, we act upon it, or maybe have conversations with other medical people like a physician, and then we get a plan, and then we go back to the patient. We have this plan in our heads that's in medical talk, and then we go back and talk to the patient in patient talk. And now the loudest voice in the room is insurance talk. So is healthcare right or a privilege? You know what I'm saying?
it's a right. It's a
Yeah.
right. It's a right. It's a right.
Yeah. So I would say, why can't I just order or get a yearly PSA then? Because I don't really trust my provider, and this all sounds a little dubious. And I phased out of high school biology a long time ago, and I just want to get the number because my wife is bugging me.
Yeah. Google says I should know.
Because there isn't really a good screening test. PSA, so prostate-specific antigen, is a monitoring test for treatment, and in some high-risk cases may be important. But for the average low risk guy, it's not a good idea, except if you accept the fact there could be a discovery and a related freak out for something that was never much going to be a problem. Okay.
Yeah.
It's just for the numbers I got were screening from Up to Date. Screening has to happen for about 1,000 men before 3.1 men benefit. I don't know what 0.1 of a man is, but whatever.
The one-legged ones.
So really, if you're screening, if using this test to screen 1,000 men, that means it was worth it to 3, pretty much, and then the rest of them, possibility of freak out or invasive stuff that they didn't need.
Right. So, but for those 3 men, they're going to say, then you should test the 1,000 so that the 3 can live.
Totally.
So.
Yeah. And so I looked at some data about, oftentimes in medicine, one value is not really helpful, but you kind of gain information if you have repeated values over time. So think about that. This is kind of like frames in a film, that you understand more about the movie if you see more frames. But if you're just looking at one frame in the film, you're like, I don't get it. So,
That's true.
So
Context matters.
yeah, so even long-term regular screening didn't really lower mortality in a significant way.
For prostate cancer.
For prostate cancer, looking at repeated PSAs for prostate cancer, no decrease in mortality.
So that doesn't apply to all things, just for the PSAs with prostate cancer.
Right.
Okay.
For example, pap smears in women, if you get a yearly, or now it's every 3 to 5 years, it might be 7 to 10 at some point, but 3 to 5 now, if you have normal screening and your risk is average.
Okay.
Right? These are important caveats. So if somebody gets a pap smear at the recommended interval and has low risk, that definitely has been shown to lower mortality for cervical cancer. So this PSA is not equivalent to a pap smear in the appropriate gender. Okay?
Okay.
So remember that tests can also, as well as having false positives, you can have false negatives, where somebody actually has the cancer and the PSA doesn't pick it up.
Okay.
Okay. What's a poor Del order to do? Well, the decision to have a PSA is a personal decision, and this is more and more all different aspects of healthcare maintenance in patient care really come down to not just doing a mindless knee-jerk ordering of tests and looking at the numbers, but to sit down and talk to the patient. And so it's a personal decision based on family history. So there's some BRCA genes that can be involved. If somebody has that genetic history, has history of close family members, dad or brother, with prostate cancer, maybe an uncle.
So if it's a BRCA gene, would that include having breast cancer in your family and those types of things?
Yeah, men can have breast cancer.
Okay.
I think it's more complicated than that, but yeah. So, and then what symptoms the man has that, he thinks is really on his mind, what's bugging him, where's his anxiety level. For some people, they're going to do like, they come with a family history. Maybe they saw their dad die from prostate cancer and they said, this was never going to happen to me.
Yeah.
Okay. And then that is their personal Waterloo. Like they can't go there and they have to know, they have to look. So, you really have to talk to the patient, and remember we have 7.5 minutes. So it might be a good idea to actually schedule a yearly appointment just to talk about your healthcare maintenance.
Okay.
Or prostate cancer, or for women like ovarian cancer, or if there's a particular health issue that runs in the family that really kind of pushes your buttons, that terrifies you, then go in there and talk to your provider. And screening recommendations are not really universal. They can be modified, and you can even get insurance to pay for it if you document that somebody has a family history,
Okay.
or that they personally have a concern because a close relative had a bad outcome.
Gotcha.
So really, deciding what to order should be based on a patient's tolerance for uncertainty. And the only test that can really diagnose prostate cancer is a biopsy. And prostate biopsies are invasive. They are associated, I think, for men in our culture with a certain amount of anguish, embarrassment, humiliation.
Okay.
And, they come with their own problems like infection or chronic pain.
Okay.
So I just saw somebody recently who he didn't have a biopsy, he actually had a TURP procedure, which was a transurethral resection of his prostate, and he's got problems. He's got chronic problems, and
Wow.
he can't really get any. And people are just going, yeah, that happens, and he doesn't understand that, why nobody quote unquote helps him.
Wow. So
Yeah.
he didn't have prostate cancer, but he went and he had
He
the
had
biopsy
he had a really invasive procedure.
because his PSA was high when.
No, I think his PSA. I don't really know actually, but it could be either way.
Wow.
And now he's miserable.
Okay, so we're just to be very clear here. Where do they go in to get that biopsy of your prostate?
To get the biopsy when the PSA is high.
Where do they where do they in the
Where do they do it?
Yeah, where in the body do they go through your side?
They go through your rectum.
Okay.
But in this case, this guy was transurethral. So
Which is
that goes through his penis and his urethra. So the
Okay.
tube he pees out of. But it kind of depends what you're looking at. Because after you get a PSA, then and after you get the biopsy, then you get something called a Gleason score if it's positive for cancer. And Gleason scores define treatment. That's a more refined understanding of what's wrong. If your Gleason score is low, then it's probably nothing to worry about. If your Gleason score is high, then that means your risk of a bad outcome is higher.
Okay.
But still, again, to tell somebody they have prostate cancer and don't worry about it is hard for patients to hear.
Well, yeah, right. Because you hear cancer and you think I have to have all of these treatments done,
Right.
but does the provider sit down and just explain, like, you're 70 years old,
Ideally,
this will take 30 years before it ever causes you to have symptoms to grow because it's
Right.
so slow growing, and
Right.
that would make you 100. Do you really think you're going to live to be 100?
right.
Is a patient capable of listening to that, or is a provider
Well,
capable of?
actually, this is a good question. If we're out in the weeds a little bit, there are some studies to suggest that if the word cancer comes out of a provider's mouth, that like the understanding of the patient kind of checks out for actually a minute or so. So that if you say you do not have cancer, they miss the next couple of sentences, which are usually important. And all you have to do, you don't have to say, yes, you have cancer. You can just say, no, you do not have cancer, but just the word terrifies people.
And then you hear, right, it's like, it's okay, it's fine, because we gave them printouts of all of their information. Well, when you have a sixth grade reading level and that information is written at a 12th grade level, that information still is not going to the patient. They're still not getting it.
Right. Oftentimes those pages of information get tossed in the back seat of the car.
Because they can't understand them.
Well, that totally.
Yeah.
Absolutely.
All right. Sorry for going in the weeds.
And then they, then we get a call from the wife or somebody that says, he said you didn't tell him anything. And you're like, pretty sure I did. So anyway, it's the ongoing struggle. And that's why actually PAs are so good, because in my opinion, we're really taught to translate well and to communicate ideas well. But we have 7.5 minutes. So nevertheless, screening for an average male starts at age 50 with a PSA, even after all the stuff we said, because they don't have an alternative.
Wow.
They don't have an alternative. But really, what really needs to happen is there needs to be a sit-down discussion about the pros and cons, and a detailed family history, and And what I'm hoping is a little bit down the road, and I know there's research going on actually in Spain with the Spain equivalent of the National Institute of Health, because my very bright daughter went over and helped him for a summer in Spanish, looking for other screening tests for prostate cancer from
Oh, wow.
urine. So I know that there's efforts to get a better test.
Okay.
Okay, ongoing. And to be a good test, a good screening test needs to be not invasive. It needs to pretty much be right most of the time, with an acceptable and understandable amount of not right a certain small amount of time, and and have to be repeatable. So let's say every year or every 5 years, something
Okay.
like that. So we really need a better test, is the bottom line. Talk to your provider if you feel like you need testing, and make an informed decision. Don't just bring in the list. That really think about what question you're asking, because this all starts about what question are you asking. What you're really asking, if you're a middle-aged man and you want prostate cancer screening, is, do I have something that if I took care of it now wouldn't contribute to a miserable death later?
Okay.
That's the question, really. And the fill-in information is, this is my family history. This is the worst way I could ever think of to die. So this is what keeps me awake at 2:00 in the morning. How can you help me navigate this?
Okay.
And right now, the PSA isn't really the answer to most of those questions.
Wow.
Yeah.
And we still recommend it for men over 50, right?
Yeah.
Okay.
And because we don't really have anything better. But I think there's stuff in the pipeline, and I think it'll change
Okay.
soon enough. So kind of exciting. So my advice is, like what I said, make a dedicated appointment. I think it should be yearly. I think one should talk to all the concerns they have in their health. It shouldn't be a knee-jerk, I'm going to order all these tests and maybe I'll get back to you and when I get the results. It should be, no, well, slow down there, cowboy. What's important to you? What's your family history? What makes sense to screen? How are you going to screen? What's the follow-up? For example, with colonoscopy, which has been really successful, a screening tool to decrease mortality and morbidity from colon cancer. People they don't want the full colonoscopy, because who does really? What they want is to take the little card home, and with the intention of bringing it back. So
But they don't bring it back. It's like they don't want to give their poop to somebody.
I have 2 in my bathroom right now. I'm not even admitting to pooping. So I am even that far. Okay. So so if you're going to do it that way, have a plan for
Lynn, send them back. Everybody poops. We know you do. We do it
right.
too.
And the lab is
And they see poop all the time. That's what they're expecting to get.
They really don't.
They really don't.
Yeah. But so if you're not going to do what's recommended, have a plan and have a plan that's logical and stick to that plan. i.e., if you're not going to immunize your children, have a plan to protect them from the measles outbreak that's currently in Oregon.
All right.
Okay.
And if you're not going to poop, then have a plan for that too.
Right. If you don't want the surgeon to see your butt, because sometimes you have to be his waitress at the Good Harvest or something, then believe me, he's not thinking about your butt. He has no clear idea. He knows you. What's your backup plan, and how are you going to stick to that? So that's kind of. It really needs 2 dedicated visits, I think, at least, especially as you're aging.
All right.
And don't be offended if they tell you science doesn't care because you're too old now.
It's a whole thing with morbidity tables, and they're pretty accurate. What are we going to talk about next week, Lynn?
I have a physical therapist who's been helping me out via Zoom.
All right.
Really cool dude, PhD in physical therapy, lives in Portland. And we have Zoom meetings, and he helps me with the ankle surgery I had recently. So my hope is I can have him phone in next Sunday and talk about it, because for rural communities now, physical therapy is super impacted in our community. We only have 2 physical therapists or therapy practices within Del Norte, and one is only for people that have had surgery and one is months behind. So this is a way to lighten the load and to have people get, like me, physical therapy made a huge difference for my post-operative recovery.
Nice.
Yeah.
Well, I look forward to talking to him next
Yeah,
week.
he's
All
a
right.
lovely man.
All right. That's great. I'll see you next week.
Bye-bye.